sponsor as well as a session sponsor. HMA, Arizona HFMA really appreciates your ongoing support of our chapter. It's my pleasure to introduce our session speaker, Callie Christensen, whose day job is Regional Development Manager at Professional Credit. Callie is also on the board of our Arizona HMA chapter, and I'm proud to say as a friend. So we can go ahead and take it away, Callie.
Hi, everybody. It's so good to see so many faces. So in case you missed the number on Bart's update at the beginning in the opening remarks, this time last week, we were at like the high 80s, and Arizona HFMA usually gets a pretty good push at the end. But to say that we've over doubled our attendee base for the fall conference, we landed at 161 of you. So thank you so much from our provider community for joining us today and for my session. We're going to go ahead and get started. I'm going to share my screen, which is always exciting. Bear with me just for a second. So this is our roundtable tomorrow. You may have heard this in the opening remarks, but please mark your calendars because between 12 and 1 Pacific time tomorrow, we're doing roundtables. I just had Heath Ledger's picture pop up on my attendee list and he looks dashing. So it was a little shocking to me. But at Professional, we invite you to come cameras on tomorrow during that roundtable session for your chance to win this super sexy tech bag. Now, I have to tell you that this tech bag was in a hot commodity around our office. What I mean by that is it was such a popular offering when we got it for the contest that we actually had to go back and get a few more. So it's definitely something that I recommend you come. You don't have to stay for the whole time. Just come and go cameras on with me for your chance to win. So I'm gonna bring up my slide and we're gonna go ahead and get started. One thing I wanted you to be really aware of that we're doing a highly interactive session today. So we're gonna be working chats pretty heavy. I'm gonna be asking you questions. I want you to feel free to drop it in the chat. We're gonna do a couple breakout sessions. For the breakout sessions, we're gonna invite you to come cameras on. Now you don't have to be cameras on unless you choose to during this presentation because sometimes it's nice just to take your face filter off and absorb the content and not worry about it. We love to see your faces. So however you want to share your time and talent with us, but just please plan to come cameras on for the breakout sessions. We have 2 of them throughout the pendency of the presentation. So we are slotted for 90 minutes together. And I'm sure you're imagining like, how could I possibly handle all of this energy for the next 90 minutes? I promise you that if we get through all of the content and your questions, I will happily give you some time back in the day to augment your life break as long as you promise to come back with us at 3:30 for the next session. I just want to do a tip of the hat to Kelly Bauer. I think she's in here. Meg, is Kelly Bauer in here? Is she in?
I am.
Can we put her on spotlight just for a second?
Oh.
None of this was planned, you guys, but I just need to formally recognize Kelly Bauer, who looks like $1 million today in her power green dress. Where is that face? She needs to come, Megan, please. Because Kelly Bauer made a huge announcement today.
Oh, gosh.
Where is she? You can't
She's on.
Oh, can we spotlight her? Because I would
spotlighted. You probably can't see her because you're spotlighted too.
For heaven's sakes, as long as you can see Kelly and not Callie. So everybody, round of applause and huge applause for Kelly, who entered her PhD program. I think today was your first day. Is that right, Kelly?
It is. So if you need me at 6 p.m., I will be on a computer.
So you didn't quite have enough to do being the program chair for all of the Arizona events, building a new house, and just being fabulous in general. You actually decided to go for your PhD. Tell us more.
No, this is about you today, Callie, but thank you so much for the shout out. That was very sweet of you. I'm happy to share the stage with you for 2 minutes, but I know that we as a program committee were just delighted when we asked you to join us today as a speaker to share your time and talent. So it's not about me. It is about you today, Callie Christensen.
Dr. Bauer, ladies and gentlemen, Dr. Bauer. You guys, it's that kind of depth of character and bench strength that Arizona HFMA enjoys. So thank you so much for the commitment that you shared with us today. And without further ado, we're going to go ahead and get started. So bear with me just for a second. All right. Can everybody see my screen? Drop it in the chat if you would, please. All right. Everybody good? You can hear me. You can see me. Yes? All right. Thank you so much. I'm going to move this out of the way. So professional, you might have recognized that we've gone through a new look. We have a new brand and we're pretty excited about it. We think it's pretty sexy. It's still the same business lines that you know and love. Professional credit is our aged receivables side, and N-Source is our self-pay and early out service line side. But both of them are Pacific Northwest. We've been in business since the early 30s, and we've been HFMA peer reviewed since 2014 year over year. So it's a pretty amazing opportunity. If you're interested, come see me at my booth. Stop in tomorrow and I'd love to tell you more. A little bit about me. I've had some changes since most of you have seen me. Doesn't it feel like forever since we were at Talking Stick Ranch? We were virtual last year. We were virtual again this year. Again, in an abundance of caution, right? We had no idea looking down the magnifying glass or the glass ball where numbers would be. So just in an abundance of caution. And again, as Joan said in her opening remarks, to answer the need of our providers, right? We know, depending on the system, you might be remote full-time, you might be doing a hybrid, but either way, your time is in high demand. So again, we're grateful for your time and talent today. I've been involved with Arizona HFMA for 3 years. I was a past program chair last year, and happy to be a director on the board this year. So as you look at my family here, we are living the tiny home life. We made a pretty big change about 6 months ago and moved off grid. But before you think I'm too crazy, don't worry, I have internet because you can see me, right? And we have all the power that we need through solar, and we do some generators. But I also have expanded my flock and family to include, we've got koi fish, we have chickens, we have ducks, we have turkeys. I'm historically a dog person. You can see our boxers there. Kai is the older one and Kana is the one kind of looking in profile. But we also have cats now too. So here's a next chat opportunity. I want you to take a shot in the dark, dropping in the chat how many animals you think are in my flock and family. Flock in families. So tell me what you think. Drop it in the chat. I have to see. All right, where is my chat feature? Someone's gonna have to read it to me. Allie, what are people saying in the chat?
We've got 12, 42, 14, 27, 15, 16, 17,
Who
8.
said 27? Who was it?
Oh, let's see. John
Allie,
McMullen.
the secret sauce behind the scenes. She's our latest addition to the professional team. She's our are you a millennial or a Gen Zer?
I am an elder millennial.
An elder millennial. She's helped me to look amazing. Thank you for all of the work you've done, Allie. Who said 27?
John McMullen.
Woohoo, John! I have actually no prize for you right now, but just a round of applause. That's exactly right. 27 animals. So the frequency of my life is a lot different than when I was living in northern Colorado. We're now in central Colorado living at 10,000 feet. So anyway, that's a little bit about me. I speak nationally. It's my pleasure to be here today. And we're going to go ahead and jump into the content because I bet you probably feel like you know me now. So the next thing in the chat, I want you to tell us, what was your largest revenue related challenge over the last, does it feel like forever? Let's be specific to COVID. Let's be specific to the last 19 to 20 months. What was the biggest revenue challenge that you guys had? And drop it in the chat. I'm gonna have to stop sharing just so I can see the chat for me for just a second. Biggest revenue challenge, collecting money from Kobe. Give us more on that. What do you mean, Kobe? We get it. Telehealth, okay. Transitioning team members from office to remote. That's from Tori, and Tori's at Banner. Y'all are fully remote for Banner. Is that right, Tori? Feel free to drop it in the chat. I think I heard Banner is 100% remote. Barb said the suspension of elective procedures. Right. How hashtag ironic when we usually use those margins to make magic happen other places. Payers moving. Yes. WFH. Gladys. Gladys, we have so many, work from home. I knew what that was. I just had to find it in my archive section. Thank you, Gladys, for that. Fewer deliveries. So lots of revenue related challenges. You know, in doing some research for this presentation, a lot of the providers that I talked to said, look, Callie, we're in a better position this summer than we were last summer, because last summer everybody was real time having to develop new processes, new procedures, new codes, new templates, new everything, because none of that really existed beforehand. Do you guys agree? Did that feel cumbersome for you? Because it wasn't just us on the provider side having to build processes on the fly, but it was payers as well. And everybody's dealing with the staffing shortage. So Kobe gave us one more challenge of proper form completion for remote patients. Yes, and we are going to talk about how automation and AI can help us with that in just a little bit. I might have to pay Kobe some extra points for that participation. 100%. Okay, thank you guys. Please forgive me as I toggle back and forth between sharing screen and not, because I can't see the darn chat when I'm sharing my screen. So we'll go back. So as we look back on trending over the last 18 to 19 months, we've seen a lot, obviously, as you said, challenges collecting money, challenges getting patients back into the shop. Even once we were able to resume elective or scheduled procedures, there was a lot of perception of fear. Do they really want to come back? So that telehealth component that I think Kobe threw in there is something that, as all systems, you know, we're working to embrace hand over fist, and we really covered that in the last conference, so I don't want to be too redundant. But what one system's experiencing at end of year as they're trying to balance the budget is what probably most of your systems are dealing with as well, and that is, quite frankly, at the end of the day, an inability to balance the budget, specifically in relation to your projected labor costs. I have a local system in the Arizona market that will remain nameless, but are prognosticating that they're going to be in excess of $80 million over what their 2021 baseline was for their wage costs. So that's incredible. That's hard when all of those other things that we were talking about are happening at the same time. So the point of our conference today is getting back in the game. So let's hashtag get game on and talk through innovation. And what can we do to innovate our processes and to relieve burden on our people? As we move through this presentation, you guys, I don't want you to think about bots and AI and machine learning as something that you're going to use in place of your employees. It's what I'd like you to consider using in addition to your time and talent, because don't you want your people working at the top of their skill level? So the whole big takeaway is, what can we do to utilize our EHR to the maximum capabilities to not just cut vendor costs, but to give time and talent back to our most important asset, and that's our people. So we're going to start today talking about staffing shortages, and we're going to spend some time here. We're actually going to do a breakout session where each one of you are invited to come cameras on. You don't have to do anything. Don't get scared. We'll take care of all of the work behind you. You'll simply need to click accept the breakout session and we'll take it from there. But we're going to talk about, with staffing shortages being such a reality, whether you're in an urban or a rural setting, what are systems and hospitals and provider groups doing to fill those frontline positions that historically are pretty hard for us to fill? Or if we get them coming in the door, how do we keep them? So much like patients, you know, welcoming them in, employees into our system is only half the battle. Once we bring them in, we want to keep them there. And then we're going to talk about bringing in the bots. We're going to talk about day-to-day bots and things that major systems around our region are doing to clean up the manual errors, to clean up defects before they become mistakes. And then we're going to talk about how you can level up your bot strategy and your automation by optimizing your EMR. And then we're going to close today with all of the different areas providing us legislative headwinds. And it's several. I mean, there's just so many rules and regulations that are coming down the pike. You know, it used to be we just thought we had to worry about price transparency. Oh, I think we'd like to go back to the time where we just had to post charges, not 300 in our contracted rates. So we're going to talk about that today as well. So this quote really was kind of astounding to me, and I want to check in with each of you as you have the ability to chat. Actually, we're going to change it up this time. We're going to change it up. We're struggling. We're really struggling. We don't have the nursing capacity now that we did in January. So this is in Oklahoma, right? But I hear about places all across the country that are in that same position. So what I'd like to do is, first of all, for those of you that need a little Zoom primer, if you look in the upper right corner of this display screen, you'll see what looks like a little Rubik's Cube. Click on the gallery view. That way we can see all of your beautiful faces. Now, we have 3 pages of beautiful faces, actually just 1 page of beautiful faces and then 2 pages of phone. But anyway, feel free to come camera on for this. All of you are coming back to me. Hi, Barb. Nice to see your face. Pretty in pink. All right, we got more people coming. All right, so here's the deal. Now, when you look at the bottom of your toolbar, do you see the reactions? I want you guys to give me a thumbs up. Not that we're happy about it, but a thumbs up that's an indication that yes, this is your reality if you are currently experiencing staffing shortages, from compliance to nursing to housekeeping to food service, whatever it is. Thumbs up if you are experiencing a staffing shortage. We're not happy about it. We're just visually managing how many people have that staffing shortage. Okay, so it looks like we have some, but not all. I have to tell you, I thought we'd have more thumbs up. Again, not that we're happy about it, right? But it is such a reality that we're hearing. And then drop in the chat, where are you guys dealing with your biggest staffing shortages? Like where are you seeing that? Is it your frontline staff? Is it your access and your registration staff? Where is that happening within your system? Is it your rev cycle? I know you want to come audio on. Nursing, medical assistants, rev cycle, med assistants and RNs. That's what Kate said. Absolutely. Medical assistants, registration staff. Okay. ED, frontline. Yeah. Our access and our frontline staff, you guys are not alone. I know it doesn't make us feel a lot better that our peers are in the same position, but we've had to get really creative. And, you know, internally, we're trying to figure out what that sweet spot is between keeping people remote and bringing people hybrid. And it's kind of a dance within rev cycle, right? Because historically it's been coding and HIM that got to work from home in their bunny slippers, right? But now it's everybody. So how are we balancing that? You know, the quality outputs and the productivity. I know our morale went up when we deployed remote, and, you know, we had to learn new ways to communicate. But now it seems like we've kind of turned that corner, right? We had a lot of institutional inertia, I think, about working remote and deploying remote, but I think we might have turned that corner. Here we go, fingers crossed. So, all right, I'm gonna go back to the share screen, bear with me. All right, so we might be in a similar situation than Oklahoma, but hopefully we're not in the same situation as Boise, Idaho, that actually had to deploy the National Guard to help with coverage in their medical facilities. This came out, I think it was about a week ago, where they started to deploy National Guard just to help with the volume and the overwhelm. And, you know, I was talking with a provider yesterday and she said, Callie, we've only got 3 beds left in the system. And I said, but you're a 9-hospital system. And she said, I know, that's the issue. So for many of us, you know, we're retooling ICU beds and doing the reverse flow for the oxygen. But, you know, we've just seen so many changes. It's hard to know what we're coming into. So ultimately, no matter where you are in the country or whether you're dealing with pediatrics or specialty care, we're kind of all in a situation where we're having to widen the tent and thin the soup. And it was a situation where I don't think any of us ever thought that we'd be in, not being able to provide substantive care to anyone who presents. But the reality is, as volumes continue to increase and our staffing resources decrease, we are in what the American Nurses Association says is a critical human resource shortage. That was really hard for me to say. Human resource shortage. There you go. I've got the links at the end. So if you want to do any further research on any of the things we're going to talk about today, and I invite you to do that, I just want to like wet your whistle on things that you can be thinking about and then empower you to continue the conversation on demand. So I've got all the links in here for you. But it's pretty tough. And, you know, a lot of us just thought that the PPE and the ventilators in the beginning were kind of the biggest thing that we had to worry about. And this is actually going to be another area where we're going to jump in and get a little bit of feedback from the audience. But don't worry, I've got a story for you first. I was touring the new Mayo facility. They've been doing a lot of construction on the Phoenix campus. This was a few months ago. And I had an opportunity to run into one of their supply chain gentlemen and get introduced. And I couldn't miss the opportunity. I said, help me understand how we are pivoting from a just-in-time supply chain system. That's really, whether you think about the grocery store or cars or any sort of supply chain, we have historically been just in time, 2 to 3 days of supply. And so that doesn't work in a pandemic when everybody's clamoring for the same supplies that may have to come across the ocean to get to us, good, bad, or indifferent. And so anyway, I didn't say all of those words to the facilities Mayo guy, but just to give you some context. And he said, Callie, he goes, I've been pushing for over 20 years for us to get our own supply warehouse. And finally, through this PPE crisis, we are building our own supply warehouse and we will be making our own PPE. And he's like, and it'll be right there. And he pointed to where it was. And he goes, but the joke's on me because I'm going to retire before I'll see it actually built. But he knows. So that's my question to you is, what have you done to change your internal process? Let's keep it specific to PPE if you know it. I mean, obviously we're rev cycle and finance people, we're not supply chain, but I just love to hear if you guys have made any changes as we're coming into the fall season. And drop it in the chat for me, please. I'm back with you so I can see your chat responses. What have you done to change your supply chain, if anything? Are you building your own supply warehouse? Like Mayo's got deep pockets. We don't always have that ability. I've heard other hospitals and systems cleaning and reusing their own PPE. So what are you guys doing? Does anybody know? Let me see here. I don't see any responses in the chat. Did you guys all lose? Okay, mask use changes. Thank you. Thank you for coming back. Central storage of PPE and reusing. We just have stock in the central supply. Okay. Changing linens less often. Things that we have, that's examples of widening the tent and thinning the soup, right? What can we do to make more use out of what we actually have? Excellent. Thank you, guys. The donning and the doffing is huge, right? And I think, you know, in between rooms, donning and doffing, even if you're rev cycle just making rounds on payment stuff, donning and doffing is kind of a full-time job in and of itself. So thank you, you guys, for contributing with me on that chat feature. I certainly appreciate it. And as we talked about through the chat with our medical assistants, our RNs, our nursing staff, there is a significant amount of burnout. And the reality is not that it's always about money, because I think we're seeing, you know, through the society, there's a few different reasons, not the least of which is burnout for the last 19 to 20 months of hard-hitting stress and care management. But traveling nurses, quite frankly, can make 3 times the money and have a little bit more a lot more flexibility on their hours. And that's where places are going. And I think part of the reason why our wage costs are hard to forecast and budget for is because we are having to pay a premium to get these employees in the door, and then of course try and keep them there, right? Because that retention piece is such an important, it's actually more important, right? Because now they're a trained asset and they have all of the skills and ability. You want to make sure that they stay. So we are getting ready for our first breakout, and I don't want you to be nervous, you guys, because it's going to be fun. Again, you're not going to have to do any work except simply accept your breakout room, and you're going to come to either my room or my beautiful boss's room, Lisa Kirk, and she will be hosting with Gidget Bowers, who you met at the top of the call. And we're just going to talk about cameras on. What changes have you made regarding staffing? If you have any more information regarding the supply chain, and specifically as it stands right now, what would you say your largest pain point is, right? So we kind of got through the initial staggering of the denials and trying to understand how to like queue the claims and not push them out until we were ready and needed to have the modifier in order for Medicare to pay and all of these things. And how do we deal with an, oh, by the way, of a COVID test during an office visit and all of those things. So we've got tons to unpack in a short time to do so. What we're going to do is we're going to roll you to a breakout room. Again, you just simply have to click accept your breakout room, and you'll be there for just a few minutes, and then we'll come back as a group and debrief. So it should be fun. It should be exciting. And Megan, I think we're I was so happy I got back to you. I was like, I hope I can get back to the room. My system was buffering. All right, welcome back, everybody. Was that terrible? That wasn't too bad, was it? Again, feel free to click on the gallery view in the upper right corner so we can see everybody's beautiful faces. Lisa, I'm going to start with you. What was your room talking about? What was the chatter for your breakout session?
We had great conversation in ours. We talked about the biggest changes, and of course, no surprise, it's the staffing and the moving to remote work. Some really great stories of how everybody shifted to a different work model. What Gladys shared is how the Banner staff typically would have taken 100 hours of meetings to figure out how to deploy all these people remote, and they were able to do it very quickly with people bringing in their laundry baskets, right? Putting in their computers and taking them home. She did want to make sure that we knew that they still did get their 100 hours of meetings in. It was just after everyone was deployed remotely. A great topic that I wish we would have had just a couple more minutes. We thought that that 10 minutes was going to be a long time, but we actually needed some more time because it was brought up, Barb brought up from Honor Health, what are you doing for people who have families? We're seeing women leaving the workforce at numbers we haven't seen for a very long time. And that's really concerning. And Tori with Banner shared how they were sending out options, childcare options through the Y, and offering a lot of flexibility. Somebody put in the chat that flexibility is key. And it would be really great to continue that conversation and just find out, are your systems staying with that flexibility? We know in the last year when kids maybe were on Zoom meetings for school, that flexibility had to be there. Have you found now, as we all have lots of open positions, that the flexibility is something that you're keeping? So for another day.
I am so proud of you. My boss, ladies and gentlemen. Let's give her a round of applause. She did a great job. So really good conversation. And isn't it ironic that you ran out of time too? Because we did also. And I was like, oh, I guess we should have given it more time. But, I wanted to bring a couple things that we talked through as our group back to the larger community as well. Now, I want to add a little bit of context here because I obviously am on a partner side. I'm not a provider, but with the understanding that in HFMA space, we need the diversity of all our brothers and sisters, and we don't think the same, and we don't all talk the same or act the same, and that's the way we want it, right? In this session, we're not going to talk about politics, and we're not going to talk about religion because that doesn't have any place in where we are today. But one of the biggest hot button issues that came up for my breakout group was it was a twofer. And so Kate, are you still with me, Kate Brown? Because I would love for you to tee up your question because we're going to bring it to everybody. So Kate, are you with us?
I am.
All right, there you are. I see you too. Let's spotlight her, please.
Yeah. So one of the bigger issues that we've dealt with at Phoenix Children's is the ability for only like one parent and the LAR to come to visits. A lot of pushback, a lot of frustration from parents that the practice managers are dealing with because obviously we're frontline and we have to do all the talking to them when those situations come up and they're furious about it.
Did you say Mama Bear? Did you say Mama Bear and Papa Bear?
I said Mama Bear.
I did. I did because you want to see those animals come out. It's with our kids, right? And as fiercely as we care about each other, we care about our kiddos even more. So that was a huge thing. And then there was a secondary piece to that, Kate.
The masking?
The masking and enforcing the masking.
Having to wear masks, and it sounded like someone had issues with their PAR staff having to deal with people not wearing masks frontline.
And pushing back.
Right.
So Kate joining us on vacation, ladies and gentlemen. We're so grateful for her time. Megan, thank you for spotlighting her. She's like, and we're done. And okay, back to Callie. So, all right, what we're going to do is we're going to drop it in the chat just to kind of build a common ground. How many of you are having, again, it's not just billing and claims processes that we're having to redo. We're coming up with new policies and procedures on care treatment and limiting parents to come in. And then, of course, the masking issue. Drop it in the chat. Is that an issue for you guys? If so, what are you doing? Oh, look at all the chats. We have such a great one. Lots of masking. Jill, can you tell us, because it looks like you amplified the masking message. Jill, Tom, I don't think you can do a video. I think you texted me and said that you couldn't do that, but maybe you could drop it in the chat. Anybody else having issues with that? If it's not appropriate for the larger group, I'm happy to move on, but it seemed like quite a few of our hospitals and systems were just dealing with that. Tori says masking has been an issue, especially once masking requirements were lifted, but now they're changed, right? Because regardless of vaccination status, most places are asking for us to mask in an abundance of caution, right? Obviously, we've seen volume go up. That is hilarious. Cynthia wanted to know if her bedazzled mask would be up to spec. Brandon, I don't know. What do you think? Oh, I got eye contact. He's like, wait, am I on audio? I don't know. Brandon, do you have a bedazzled mask? He's like,
oh yeah.
Oh, you do?
Oh yeah. No, Bart, Shay, and I, we get together the second weekend of every month, and we just go to town making them ourselves.
So it's like matching butt pocket bedazzle with your mask. Is that kind of how it goes?
Yeah.
Got it.
We choose themes. Sometimes it's our favorite football team. Sometimes it's our favorite My Little Pony character. It really varies.
Charlotte makes a really good point. Thank you, Brandon. Sorry to put you on the spot, but I'm happy to see your face.
I just didn't. I didn't realize you knew that about me, but I'm glad I can share my passion with everybody.
Well, we appreciate the support that you bring to our chapter. So I always want to give you a little mic time if I can. Charlotte makes a really good point. Different states have different requirements. So if your system works across 9 states like the Banner system does, there's some headwind that way, right? Not just with your patients, but also maybe with staffing. So I think the biggest message there is message received that it's a challenge across all states and all systems, and nobody actually has the magic answer, but it says mask or no. That is the question. Some of the patients just gave up and refused, and I think we're seeing that as a macrocosm, just like with our kickoff presentation talking about micro processes and macro processes. What we're seeing in our hospitals and systems are representative of what's happening at the larger societal level, and we all have broken brains. We all are like cognitively have cognitive dissonance on what is the right thing today, and we all want to follow the rules and do the best for our community, but just trying to keep our brain together and understand what's expected of us when the goalposts feel like they're changing. So I'm going to go back to sharing. I'm going to see if I can do that as seamlessly as we did the breakout sessions. Bear with me. Of course, my slide is gone, so I'm going to need to find it. I don't know where it went. There we go. So all right, we made it through our breakout session. The next question, we're going to switch gears a little bit, and we're going to have to put our thinking hats on. What is the difference between automation and machine learning? You're going to drop it in the text. There's no judgment. This is a judgment-free zone. None of us probably self-identify as speaking geek or teching out, so you don't have to have the official definition. You can Google it if you need to, but I want you to drop it in the chat. What's the difference between automation and machine learning? And you can do a little abbreviated version of it in the chat if you would like. What do you think? What's the difference? And if you're like, Callie, that's why we're here, to see you right now. You're supposed to tell us. I promise I will. But I'd just like to hear what your thoughts are. So Brandon says AI aspect. I don't know what that means, Brandon. He's laughing at me. I'm that much of a geek. I know I am.
Artificial intelligence.
Well, I know AI, but what is AI aspect? What is that?
machine learning isn't full-blown AI, but it has more of an AI functionality than just pure automation does.
Got it. Megan, machine learning looks at a pattern to replicate and then automate actions. That was pretty fancy, Megan. Good job. Automation does the same thing every time. Automation can include screen scraping and scripting to do simple rote tasks. Good job. Kobe, what is machine learning? She Googled it. She gave it the Google. Automation is written in code. AI takes intelligence and analyzes it. Amber says, for me, automation means a task that can be repeated automatically with little complexity. I love that. I love automating manual tasks. And I think as we think in general about rev cycle processes, we tend to think back of the house, right? We tend to think, you know, kind of what can bots do to help take away the manual processes that our time and talent, our actual human assets don't necessarily want to do. What can we do to make their lives an easier, better place to be? So when we talk about automation, many of you hit that right on the head, and that's exactly right. How do we automate with speed, reduced cost, increased capacity, increased quality, and increased consistency? Because the bot never takes a day off. The bot doesn't miss key or fat finger like yours truly does. So when you're looking to improve those types of things, automation is a great place to look. So then, as Brandon said, machine learning builds upon that. Now, I probably am not going to say it as good as he did, but the machine learning, quite frankly, in its most boiled down essence, is the machine looking to predict a pattern. And once it predicts the pattern, it creates a model and then, you know, does prognostication for that. And I probably didn't say that perfect, but the big thing is that once it identifies patterns, it can predict outcomes. And so what we're going to talk through is how some of the largest systems that you're going to recognize across our region are using automation and machine learning in their day-to-day. So one of the first examples that I'm going to talk to you about is Mercy Hospital of Fort Smith. And they really decided to focus on their emergency department patient flow. They had two metrics specifically that they were interested in decreasing. What they call LWBS, leaving without being seen, and also their door to dock time, because that patient throughput, whether it's the emergency room or we're bringing our kiddos in for their preventative appointments, tends to be a huge dissatisfier for the patient, right? Like, you know, kids or we never get sick at a convenient time. So now we're there. Ideally, we're in a telehealth, but we still value our time, right? So how long are we in that waiting room? How long are we waiting to actually see that doc? So what they did was they deployed bots within their electronic health record to do what I think one of us were talking about, scraping information out of the electronic health record in a real time and populating the intake forms. So this patient just literally needed to do an e-signature instead of filling out their actual intake paperwork. That metric moved from an 11% patient intake form completion rate to over 70%. Now, we all know how important access is. This is a shameless plug to Becky Peters and Jenny Erickson and their team, because we know they're here, how mission critical access is. It touches every department within the hospital, and there's so much of those form locators that have downclaim effects. So that was a pretty big one in what they did. Intermountain also wanted to clean up their intake and ED patient flow, and they also used a scraping program to pull information out of their electronic health record and make it easier and more satisfying for their patients and have a higher retention rate. Again, that's important, right? When we think about the life cycle of the customer, they start as a consumer, we welcome them in through our throughput, they become a patient, and then we want them to come back and bring their children and their families back. So to come back to be a consumer to our brand for the rest of their life. And that retention and satisfaction piece is a really big one. So we have a behavioral scientist on staff, and his name is Hayden Reese, and he super geeks out on this kind of stuff. And I was like, Hayden, what do you think about this slide? And he's like, Callie, I agree with everything except that machine learning could possibly ever be overkill. And what what that resonated with me, you guys, is there's some generational perceptions that come into play with bringing bots into the workplace, right? I think kind of based on how old you are, you might think of it differently. And I'm not going to cast disparaging remarks, but Hayden is a Gen Z, so he's right in that alley age bracket or group. And so they look at automation and machine learning differently than yours truly as a Gen Xer. And I think of it a little bit differently than maybe boomers do. We don't want ever to think of automation and machine learning as a substitution for our FTE. I want you to consider it as an enhancement or in addition to. Again, if we can take out those manual processes, taking away the men or the female in the processes, that allows our staff not to burn out doing they're meaningful. Claim status and things like that all add value, but it's also very rote, like someone had dropped in the chat. So I talked with Jamie Davis at Banner. Many of you probably know her. And she's like, Callie, she's like, I've got 20 day-to-day bots. And I'm like, Jamie, what are they doing? And these are the types of things that Banner's using within their system. And this is what she calls her day-to-day bots. So the status and the coverage updates, charge capture, denials, authorizations, kind of our wheelhouse and where we live, MedRec submission, and admission notification. All of those are great places to start. You know, obviously we acknowledge that not all of us have maybe the pockets to have this type of robust analytics program. But again, wherever you are, it's a great place to start. And really for our, at Professional, one of the ways that we use bots is in our law office, in our legal department, because when we pursue legal remedy, there's so much documentation that's needed, much like with medical records and appeals and things like that, that we actually have a bot that goes and puts all of that documentation together and gets it in a packet ready for human intervention. So wherever you are, there might be a process that you could start to consider to take away that manual process and improve that automation. Bots can really help differentiate the noise, because I think in our EHR or EMR, whether EHR is transferred across the country, the EMR kind of lives within your practice. So whatever you're doing, there's a lot of noise, there's a lot of information in there. And I think by using bots appropriately and ultimately building it into a machine learning platform, we can tune the frequency. You know, I've heard it said that, we're drowning in information, but starving for substance. And this is a way that we can really start to decipher information through the EHR and the EMR, is using bots to help us. One statistic that I heard in researching this presentation, 80% of electronic health record data is unstructured and we're unable to take action on it. So again, this is a way that we could consider leveling up our patient experience, right? To relieve the document burden, that we put on our staff for documentation, not just the physician's narrative, but the med recs, and they got every other page except of course the page that they want. It can be very cumbersome. And the authorization piece, I know I'm preaching to the choir as far as the prior auths. A lot of us 2 years ago thought that was our biggest problem. Oh, silly us, right? But you can see systems now working to reduce deviation and gold carding their physicians to try and cut down on that prior authorization shenanigans, official word. I also spoke with Candace Hoshi. She's a good friend of mine and she's at UC Health. And this quote came out of an interview that she did with Health Tech Outlook. If you want to read the whole article, the source is cited for you at the end. But I don't tend to read very much, but I am going to read this one to you because there is some, whoopsie, sorry about that, some value add here. Maximizing system automation within patient billing should be a priority for all healthcare systems. One of the ways we've done this was to train our system to select correct coverage based on patients' real-time eligibility. And today, more than half of our coverage is selected by the system. She goes on to say that obviously has downstream revenue boosting effects because the improvement on the first pass adjudication or the clean claim rate, reduces burden and increases revenue. So that is one small way that UC Health has been using automation and machine learning within their system. So I asked you on one of the poll questions within Whova, what were areas that you guys were using automation or machine learning? And so just for the interest of people here today, could you drop that in the chat? Tell us your system and what you're doing from a machine learning or an automation component. Where are you at? Who's going to be the first to reply? I can hear you typing happily, my little learners. What is it? Barb says inpatient status, automate the case management and the discharge. Excellent. Now, Barb, that works with length of stay and utilization management also. Are they all kind of tied together, your UR team?
Yeah. Oh, can you hear me?
Yes, please.
Yeah. It's called Exalis, and what it does is it takes all of the, like, say you have 300 patients in the hospital, it prioritizes them based on their status score. So if someone has a really high status score, then it doesn't seem like they're going to be discharged anytime soon. So they get moved to the bottom of the list, and people that are like near that middle road where it looks like they're going to be ready for discharge, then we can start working on those patients and get them discharged, get them home services, get them to a SNF, etc. And then it does also produce an executive summary for the payers that outlines, kind of what the status is of the patient. And it doesn't just send 300 pages of epic medical records. It said, here's the key lab values and why we need to keep the patient in the hospital, for those that are on the high end. But I know we use it a lot for those that are kind of on the cusp. And it helps the case managers and the utilization review folks really key in on those patients that need some intervention. Do they need to get discharged? Do they need to level up, to ICU, or do they need to get, down to SNF, etc.
Here's the magic question, Barb. Last one, and then I'll let you off the hot seat officially. It's so great to see you. Does it reduce the amount of peer-to-peers that your providers have to do getting the length of stay? Has it had any of those effects?
I'm not sure, but I know it has really helped with our case managers and folks. Instead of just starting, with bed number one, they can really prioritize their work. And that seems to make their work a lot more meaningful, which should indicate that with that executive summary, that there'd be fewer, quote, arguments over, whether someone should be inpatient or somebody should be discharged. So it does seem to be helping with that, those two areas.
And obviously, I know, Barb, but just if you feel comfortable, would you please share your system?
Yeah, I don't know if I'm pronouncing it right. I've heard it pronounced a couple different ways. Exalis, it's called, if you spell it backwards, it says no silos. So it's silos backwards, so it's Exalis.
I'm looking at it in the chat, but just so everybody knows, where do you work, Barb? Like, what's
Honor Health?
Honor Health. Yeah, I wanted you to say it. I know we've got a lot of Honor Health, and you're a recent enterprise member with us too.
Yes.
We're so excited to have you. Thank you for your willingness to join our party. And you're like, Callie, will you please stop spotlighting me? Yes, Barb, I will.
You'll probably stop spotlighting me when I stop chatting.
No, I want you to keep the chats alive and coming. Excellent. Who else wants to share? You don't necessarily have to come cameras on, but we'd love for you to, if you're brave and bold like Barb was. Where else are you using automation or machine learning? So Lorna says Cerner automating account creation for missing charges. Gladys said late charges, sending corrected claims, updating insurance information. Some of our payer notifications through census. I used to work for Cerner and Epic, so I still need nurse auditors to code directly. Excellent. Lots of areas, right? And the most important takeaway, again, that I think I want you to consider automation and machine learning in concert with your actual staff, right? Use it to enhance their jobs and get them working at the top of their license, top at their abilities, not doing the manual processes that add to everybody's burnout. So we're going to go back to the slide. I'm getting pretty good at moving back and forth. I know you guys are maybe getting a little dizzy, but again, that's what Candace had to say for UC Health. And now we're going to talk through what some of the key areas of optimization could be. And this is where, you know, we really start just thinking about the last 19 months and how many things we had to develop on the fly without a lot of guidance. And, you know, I mean, we could cover obviously a whole nother session talking about all the things that have changed with the guidelines and the processes and the procedures. But one of the first things you want to do is based on, you know, kind of what Barb was talking about, making it easier for the case manager, making sure that the med recs accurately tell the patient's story. So when they are going for length of stay or having to do a peer-to-peer to get that approved extension, that they have the information that they need to get the job done. And, you know, one of the people I was talking to with one of my clients in Minnesota, which is a different region, obviously, and Minnesota has what's called an AG agreement, which has some pretty big teeth in it. And in Minnesota, it's harder for them to use bots with this kind of stuff because they have what's called an AUC or a universal authorization completion form that has to be filled out by hand and submitted. So, you know, sometimes we can use bots and machine learning and sometimes we can't. But one of the first things that we want to do is just make sure that our access and our templates are customizable. Because that charting process already takes a lot of time, right? And especially when our volumes are increasing, anything that we can do to relieve and release documentation burden on our frontline staff, we understand whether we're on the access side or the registration side, or maybe they're the kind of the same side or the back of the house, how important this information is when we're dealing with appeals and denials. So what can we do to make it easier for our providers who probably don't want to type anything else into the computer? You know, you think doctors and providers got into the business of helping people and saving lives, not banging out Epic notes and Cerner notes. So this is one of the first areas when you're looking to optimize your EHR. What can you do to make it easier on your clinicians to make your job easier to push the paper, right? To get the modifiers that you need, the coding, to get it that clean pass adjudication paid the first time. The reporting, the 24/7 access, you know, we work off so many different devices now that to have that seamless responsive design, regardless of if you've deployed tablets to your providers or they have their workstation on wheels, whatever it is, for them to be able to get dashboard information, quick and easy ways to see how the patient volume or what outcomes are, you know, what we're up against. Anything that you can do to make those dashboards quick and easy to understand and access with the push of a button. The real-time communication, it's not just peer-to-peer, not just provider to provider, you know, across departments or through different hospitals, but it's also patient to provider. And, you know, that is one thing that we've really noticed is that patients are looking for more communication. And I think because we're so used to living in an on-demand world, I text you and I expect to see the 3 dots like immediately, like you're replying to me immediately. And don't people have that same expectation, whether we're in the business office or it's their clinician or their provider? What does Epic or Cerner or anybody else that you might be using make that's easy for doctors to talk to each other and for patients to talk to providers? A lot of times it's through a patient portal, and we're going to talk about that in just a minute. But one of the biggest areas that I would ask for you to consider start using some sort of automation or machine learning is through the e-prescriptions. And we have so many medications now that patients are taking that it's hard to reconcile them unless they stay static at one pharmacy, which doesn't always happen. That med reconciliation piece is an area where bots can really help. They can start by looking at how often the prescription has been renewed. Are they taking it within compliance? Are they maybe just taking a half a dose at a time because they are in the donut hole, or whatever it is. Bots can help us with the medication reconciliation piece. Within that patient portal, I think, like, we think about Epic's MyChart, or just making it easy for our patients to pay, which is obviously always a good thing. But what can we do to actually empower them to research whatever the disease or condition is that they might be trying to manage, schedule, refill their prescriptions, any of that kind of on-demand communication? Because you would be surprised at the ridiculous time that people are coming in to navigate these. You're like, shouldn't you be in bed right now? But I guarantee you that you would much rather have them self-serve at 2 o'clock in the morning than have staff there to take their call. So that patient portal is a big one. And finally, that area where it's kind of one of the biggest patient satisfiers. Hopefully no one on this meeting has ever had to have diagnostic services done, but when you get a biopsy, or if you're waiting for lab results, it's pretty much all you can think about. There's really nothing, it's very rare that you're like, oh, I'm just not going to worry about this. Men, it's not just us as women that do this. We know it's you too. But anyway, being able to access those lab results on demand as soon as they're ready is another really important patient satisfier, that if you're thinking about how do we level up our automation and machine learning to think beyond the billing components, right? How do I get to a patient satisfaction and, more importantly, retention mode? These are things that we would ask for you to consider. All right, so we saved the best for last, you guys. I know that you are very excited about this. It is a surprise that I'm just kidding. We're gonna talk a little bit about the No Surprises Act. This is an interim final rule. I am not an attorney. I'm not giving you legal advice. Everything that we're talking about is accurate to the best of my knowledge as of today, but things are changing all the time. So most of us have probably heard about the No Surprises Act, but being able to unpack it and understand truly what this is going to do to our rev cycle is a different story. So really, I'm just bolding some of the major things. I'm not going to read this to you. We are going to bring this into our breakout session. So if you have some comments about this, what your system's done, what you're thinking, we'll ask that you bring that into the breakout session. But surprise billing has been a loaded topic, I think, for all of us for as long as I can remember. It's been kind of an area of consternation. I've got clients in Idaho. I think we have some attendees here from Idaho. Idaho packed a particularly poorly wrapped present that hit at the exact same time as price transparency, and that was called the Idaho Patient Act. And that also was spearheaded off of what was considered a surprise anesthesia bill. And for any of us who have ever been in the hospital, God forbid that's happened, or had surgery, I think we've seen, those third-party bills coming down the pike and have been able to kind of hopefully know that it's coming and make sure that they're in network. But conceptually, I think we all understand the surprise bill. So one of the first areas that this legislation focuses on is that we have to treat everyone in network without requirements for prior authorization. Prior authorization, as we all know, is one of the biggest areas historically of headwind from the payers that we've had to face. A lot of times, if it's not obtained in the beginning, we can't get it retro, and the requirements only ever seem to get harder, quite frankly. I might be wrong. If that's changed magically, please drop that in the comments and let me know. But when it talks about emergency and non-emergency cost, patient cost sharing such as coin or deductible cannot be higher than if it was in network. So coinsurance and deductibles must be based on an in-network provider rate. And if it's anything other than that, much like Medicare has patients sign an advanced beneficiary notice, in this way, we would also need to provide the patient in advance of the service and scan it to their electronic health record, a plain language consumer notice explaining that their consent is required to receive care. And we'd want a signature on that, and that would want to be in perpetuity, scanned and attached to your electronic health record. And then, like we talked about at the top of the slide, any out-of-network charges for ancillary care like anesthesiology, or if you bring in an assistant surgeon, all has to be provided in that in-network cost threshold. So before I move on, I'll take any questions. I almost moved on. I did move on. I gotta stop my share. Drop it in the questions regarding anything around the No Surprises Act. Anything that were you guys like, surprise? I hate the No Surprises Act. Not all of our providers are employed. So what are you doing for those non-employed physicians and providers? I can tell you for the Idaho Patient Act, we had to itemize and identify any of the non-employed or third-party physicians, whether it was radiology, pathology, anesthesia, and do an attestation to the patient verbally and in writing saying that they may receive a bill. So anybody else dealing with that, with the surprised billing? I'm still seeing our amazing chat thread from previous conversations. How are you guys doing with the surprise billing? Who's going to be the first one? The suspense is killing me. Nobody. Wait, maybe it's me. No, there's nobody. Wait, let me do a test. Anybody dealing with surprise billing issues? Anyone? Hopefully this isn't new to you. If it is, reach out to me afterwards and I can send some more content just to help you get up to speed. I'm happy to do that. Oh, somebody responded. Thank you. Thank you for responding. So some additional legislative headwind, because, you know, we tend to very often get unfunded mandates. You know, we all kind of were doubled down in the middle of COVID and thought that they would push back the price transparency and your 300 most shoppable charges and your payer contracted rates by machine readable format by January 1st. And the reality is, here as we stand here in September, I can tell you that the providers and the hospitals and the systems that I've talked to, it's about a horse apiece. Some have had the compliance staffing to take on this lift and build that into their processes and procedures, and about as many have decided, for whatever reason, that they're going to take the risk. But one of the biggest variances on that decision is, are you in an urban environment with, you know, kind of system backing? If that's the case, then a $300 a day hit may not necessarily be mission critical. Conversely, if you're in a rural health environment, you know, a very sparsely populated, community critical, not only do you not have the human resource infrastructure to build this out, but you also can't afford to do the $300 per day hit. So as we go into the breakout session, this is going to be one of the main areas. Not that we're looking for anyone to self-identify whether or not they've posted their charges, but just, you know, what has it done for you? If you have decided to post charges, were there areas within your charge master that you saw you were getting beat by your competitor, maybe 10 miles across the road down the street? Were there changes that you made? Again, you can talk about that in your breakout session. But the last area that I wanted to cover, and this is an area that has huge implications for our revenue cycle, is that the U.S. Court of Appeals did uphold the cuts to the 340B program. And that, as we all know, is very significant. You know, I think we can understand that Health and Human Services wants to, quote, narrow the spread between the acquisition price and the reimbursement. But all of us at this side of the table know that, you know, that's money that we borrowed from Peter to pay Paul, generally for operational costs, and used it to meet our margins and maybe sometimes our payroll, because those discounts based on our contracts are significant, right? Between 13 to 32% off of the retail price. And our payers, as we're seeing, you know, really aren't backing down. You know, I've seen multiple letters of payers adjusting their contracts as of 8/1 and changing who they'll cover and how they'll cover. I have one of my friends here in the Colorado market that they have to do what's called white bagging. And so what I mean by that is for the high dollar chemotherapy and infusions and things of that nature, the patient actually has to bring the medication into the hospital with them. So, I mean, that's crazy. Charlotte just came on camera. Did you have something to share about that, Charlotte? I don't mean to put you on the spot, but you just came on camera and it looked like you had a burning
No,
desire.
So my brother is a hematology oncologist. And, because, I'm on the administration side, but this is something that they're having to deal with. And it's really, I mean, from a provider side and from, a frontline physician side, they're absolutely done with this. Absolutely done with this. The fact that they have, patients who are having to bring in their own chemo meds. To hear the physicians talk about this is, it's a horrifying experience.
Can you just break it down, like, just for anybody that might not have ever heard of white bagging, because it was new to me. Like I hadn't heard it before. And in my mind, it's like you said, such a patient dissatisfier. I mean, these patients are going through chemotherapy. These are high dollar infusions.
Very, very high dollar infusions. And the physicians are kind of, their hands are tied because of payers. And so they're having to ask the patients to bring them in, where it used to be where you go into an infusion center and, the nurses, the oncology nurses and the pharma guys would, put together your infusion. Now they're putting together their own at home and bringing them in for the infusion center. However, they're also being billed at full cost. So not only are they having to bring in their own medication, but then they're being billed at full cost as if they had not brought in. And some of these medications can run $10,000 a month.
And who has that? I mean, nobody, regardless of whether or not you're going through cancer. It's like I just don't even understand. Thank you.
And Medicare Advantage, it's tragic. And just from my point of view, having worked frontline, having worked administration, understanding, healthcare economics on both sides of the fence.
Right.
It's tragic because, then they've got the whole COVID thing going on. Right. So it's a very, very challenging subject that you're entering into. I don't know what the solution is. I mean, it's
well, and the payers, to your point, it feels like have the juice right now. No pun intended. Charlotte, thank you for amplifying that message with a testimonial and kind of front line. I cannot even believe it right now that we are already almost time. For heaven's sake, we have to do our breakout. We absolutely have to do this breakout. I know a couple of you want the 340B. We're going to talk 340B in the breakout session, and then we're going to pull you back, and then I'm going to get you out of here because I thought we'd run out of time, but we might just run out of time. I don't know. So I'm going to go back. Megan, do you need me to start sharing, or can you just roll us to our breakouts?
I will roll you to your breakouts.
Can we adjust the time down? I'm sorry.
Yeah, how long would you like?
I know you guys, we ran out of time last time, but let's do 7 minutes so I can bring everybody back before we're done.
Perfect. Sounds good.
Okay. All right, we're gonna wormhole it, everybody. It takes a little bit. Don't worry. We'll get you to the right room and then we'll come back. Thanks, Meg. Thanks, Charlotte.
Hey, Megan, I love the transitions between breakouts and normal sessions. It's really slick.
Oh, great. Thank you.
She is the magic behind the scenes, Bart.
She's the ninja.
We did it. We did it. Everybody's back and we have a minute left to spare. I can't even believe it, you guys. We did it. We made it through. You made it successfully, 90 minutes dealing with all that is this. And I'm so grateful for the time and talent that you shared. For those of you that came cameras on to participate, thank you very much. Gidget, I'm going to turn it back to you to close us out. It was such a blessing and honor to be with you guys. Thank you. See you in a little bit. You're on mute. We cannot hear you.
Well, that would be, it has to happen in at least one, right? I just want to say thank you, Callie, for all the energy you put into your presentation. I always enjoy listening to you. And again, a huge thanks to Professional Credit for their continued sponsorship. And a little housekeeping, we will go into a light break from 3 to 3:30, but please tune back in for the 3:30 leadership panel. So thank you, everybody, and we'll see you all soon.